cancer geriatric patients, and I particularly enjoy taking care of the advanced geriatric population. I think this is probably the one group that I'm going to talk to that knows this, but in about 8 to 10 years, two things are going to happen. First one is that for the first time in American history, there will be more people over the age of 65 than under the age of 18 in this country, followed by the fact that the Medicare Trust Fund will go bankrupt. And so we will really have an exciting time trying to see how we manage our patients. However, here's a statistic we'll see if people know about. What percentage of randomized control trials look at people specifically over the age of 75?
2?
You're optimistic.
Oh, no.
0.1%. So in a study that was published in Canada at PLOS, they took 26,000 RCTs and they said, well, let's see how many are for 55, 65, 75, 6% for 55 and above, 2% for 65 and above, 0.1% for 75 and above. And I happen to believe I've read all 26. And it's not enough information to tell us how to properly manage the advanced elderly. It wasn't until about 6 years ago that the American College of Cardiology came out with an executive summary saying, hey, wait a second, we really don't know how to manage people over 75 because we kicked them out of research. So for people like me who have spent much of our time working with the advanced elderly, if you haven't heard this phrase before, we call this the throwaway population, because we threw them out of research, we throw them into institutions, and we throw away their priorities and replace them with our own. And so we are fighting to change that concept and bring the care back to them the way they would like to have it, and truly make it evidence-based, patient-centered care. One of the programs that I helped to create, my colleague Susie Johnson did the administrative side, I did the medical side, was a community-based palliative medicine program. And the reason it's important is, okay, so we've identified these people. Now what do you do with them? How do you stop them from being hospitalized and progressing in their illness? What are you going to do? Do you have somewhere to put them? So I would sit in my office, and my colleagues do this now, and I will tell you something. I am a physician with several dozen physicians in my community practice that manage the advanced elderly, and they never see the inside of the hospital, ever. Cancer, COPD, heart failure, anything, dementia, and I'm going to show you the results and how we got there. So imagine it being so proactive and so aggressive, even at the end of life, that you can keep people in their place of residence managing their symptoms so well that they would ask me on hospice. I was so proud when I was a hospice director seeing patients, and my patients would come up to me and say, Dr. Hoefer, I feel so good, how can I possibly be dying? So end of life isn't about misery. You can actually feel very well and live until the very last day. And that's hopefully something we can learn to bring to our patients. So, when I called Larry, I said, can I do this presentation? So I took one of my CME presentations and just took a bunch of the slides out. If there's any gaps, you'll know why. So we have won a lot of awards. It's because people see the future. And when we started our community-based palliative medicine program almost 17 years ago, we looked at what was available, and most palliative medicine was practiced in the hospital. In fact, 90%. There were very few people practicing outpatient palliative medicine, so combining my FP and palliative skills to bring care to patients in their homes. And what we saw of the ones that did exist is they were piggybacking off of home health, or they required a hospitalization. Well, who wants to be hospitalized? So we created a program when I have a patient in my office that I know they're not going to make it back to see me again, that I know that the extent of their medical problems are just overwhelming, that if I send them home, I can flip a coin as to whether they could make it back or they'd end up in the hospital, and we created a place to put them, because you can't put them on home health. There are no Medicare fee-for-service programs. We created a program that could say, well, in this transitional period, by the way, we would never have called the program transitions, because everything's called transitions now. We called it transitions because this was that time, that 6 months, 3 years to 6 months prior to them being hospice appropriate, where that revolving door of hospitalization occurred, and we hated that. Patients hated it. You know, that, you know, like, I'll see you in my office, you'll go home, you'll decompensate, you'll end up in the hospital, you come home, you'll have home health. I've been the director for home health. They would go back to the hospital. This time they go to the nursing home, back to home health, back to the hospital. That whole chaos of the culture of the revolving door of hospitalization. What if we just get rid of that and give patients what they really want, which is excellent in-home, aggressive, proactive care, where they can live and die in their own home, surrounded by their own families. And so this is our model of concepts in the end of life. So hospice and post-bereavement for the family, the transitions program in that little light pink area. And if we've actually recorded 6 gero-palliative series for primary care physicians on how to understand and manage your advanced elderly, because that's the group that we really, as primary care physicians, we should be owning that. There aren't enough geriatricians, there's not enough palliative physicians to go around, and frankly, I'm not sure we need geriatricians or palliative physicians most of the time. I think that's something we should be able to handle on our own, and that's learning geriatric syndromes, true patient-centered care, learning how to prognosticate, all sorts of things that are very important for patients. But what I want to point out for all of our conceptualization is this issue of anticipatory guidance. We know what's coming for our patients, so as a part of what I love hearing today is that proactive management style. It's not just knowing what's coming, but doing something about it to either ameliorate or prevent the inevitable event completely. And so most programs, you can have a group of providers. We've been doing this now for almost 2 decades, not quite 2 decades, and I was just telling Larry, we didn't even know the term social determinants. We were just doing it because it was obviously what helped patients do better. Now we have all of these people that meet for IDTs. Some will see the patients directly, just depends on the individual patient's needs. We no longer call these things T-kits. Those stood for transition kits compared on hospice to E-kits, which were emergency kits. And now we call them hospital avoidance kits, so HA kits. We always label things what we use them for. It's easier for patients to understand. So if you have COPD, you have a nebulizer, you have steroids, you have antibiotics, and it's sitting right by your bedside. You know when to use it. You use it every single time, and you replace it once you use it. And that's how you nip problems in the bud, so you don't have to default to using the hospital. And I'd like to, talk about something today. We have this image that patients are going to be hospitalized at the end of life. We need to change that image to it's a failure if somebody gets hospitalized for the inevitable consequences of predictable disease. Nobody should have to suffer through those processes if you know what's coming and you know how to prevent it. So we have that for dementia, we have it for heart failure, they all have their HA kits. And then they have this zone tool, and we have nurses and social workers and chaplains. They're all going to the home. We partner with the primary care physician, because one thing that is problematic about all these programs showing up is that we put distance between the PCP, that relationship, and the patient. I'm still seeing patients I've known for 30 years. I'll work with somebody in their home, but you're not going to take over. That's my friend. Those are people I know. They are like family to me. So I want to be able to be there, and as long as I'm still a part of the game, that's fine. And so we make sure that those patients are still obligated to see their primary care physicians, and sometimes we get referrals from specialists. So our cardiologists or neurologists, they actually refer to us and work with us to manage their patients in the home. I would point out that with this program, which is unique to most programs, these patients don't have to be homebound. They do not have to have that Medicare Part A skilled need. They don't have to be hospitalized. The single admission criteria for these patients is they have to be at risk of starting to use the hospital as a tool for decompensation care. That's it. And we can give you some general guidelines. In fact, I was speaking to the Department of Healthcare Services for California that insisted I make guidelines. So all I did was take Medicare LCD criteria and I moved them upstream. Medicare LCD criteria for hospice, But the real issue is you all know, because of social determinants and skill sets of your patients and compliance with medication, you know intuitively which patient needs help in their home to do a better job managing their care. And frankly, that's where you find out, well, they're not taking their medicines correctly, they really do need, they have food shortages, they have all sorts of other things, they don't have the support system. Well, they have a caregiver that always comes in with them, but that caregiver when they're home is actually working against them. And so those are the types of things that we need to know to manage these patients more effectively. And so one of the tools, there's 4 pillars to this program, of course, in-home medical management, evidence-based prognostication, professional care for the caregiver. I heard a lot of talk today, but we didn't talk about caring for the caregiver, caring for the family. You have to do that. Because one of the reasons patients go to the hospital is not the patient, it's the caregiver. And if we're not caring for those folks in a way that's supportive, we're probably going to see them back in our institutions. But we're going to talk about a little bit about prognostication because we've lost that professional tool, unfortunately. There's 3 types of prognostication: time, event, and probability. Time is how long until something happens. Whenever you think of palliative medicine or hospice, people are always thinking about time until death. Well, that's one way to think of prognostication. Probability is, how many side effects am I going to have? I'm going to have a blood clot after I have my surgery. But event prognostication is the one that really matters. What's the next event in the expected series of events? And how do we proactively manage that or ameliorate it completely? And then you have to know Medicare's criteria for maximum medical therapy. And because if the patient is on our program for heart failure, systolic heart failure, but they're going to go for a CABG, they may disqualify themselves, and we just wait until they've had their decision to have the CABG or not. If they do have the surgery, that's fine. We'll see how they're doing, and we'll bring them on if they're appropriate, if they're still at risk. If they decide, I'm 90 years old, I don't want to take the risks, there's too many problems, we'll take that patient on and manage them from there. When you prognosticate, you need to be using more tools. Some of these tools, just general information, older folks, male, BMI, weight loss. Depression matters. I don't know how many people look at depression. 35% of patients with depression end up institutionalized after major surgeries, and that compares to about 7% for people who are not depressed. And then you have to look at geriatric syndromes. And I would say right now, if you are not teaching or you don't know how to evaluate 3 major syndromes, sarcopenia, frailty, and delirium, that's the future of managing the advanced geriatric population. So you take all this information, you look at biometric models, functional decline patterns, disease-specific and non-specific laboratory data. You learn to see what type of a prognosticator you are, whether you are overly optimistic or accurate. Most of us are markedly overly optimistic, even as physicians, especially because we've had no training. That's how you can make yourself a better prognosticator. These are just examples of biometric models. Everybody's seen these and think everybody knows about them. You have to get used to them and you have to start using them. Everybody knows about the 4 functional decline patterns, except I'm going to make a comment here. So when you see cancer right now, cancer's changing into this down here. And on transitions, this is just a straight line now. There's no more dips. I mean, people aren't decompensating because they're proactively managed so well. It's just a straight line until they're on hospice, and their only decompensation is their final decompensation, and then they die. So imagine that. Imagine having an end organ disease for which it's managed so aggressively and so proactively that the hospital is a second afterthought. Actually, you would think of it as an error or a failure. This is a very important slide. What's the median length of stay on hospice in this country?
1 week? No, 2 days?
It's about 17 to 22 days, depending on the year. So it's about 2 to 3 weeks. This is the problem, and this is the problem for us and for our families. This is ADL decline as patients approach death. And it's on the bottom is cancer, and then you have congestive heart failure, COPD, diabetes, stroke. And what do you see between 12 months and 6 months out? there's almost no ADL change. There's no functional change in those patients. And we use our eyes to see terminality instead of using our professional skills. So if you're relying on the patient to look sick or look terminal because of the media or other false ideas about what terminal patients look like, you're going to miss it. In fact, 17 to 22 days is when the patient's imminent. So we're referring patients to hospice when they're imminent, not when they're terminal. If we caught that upstream proactively, we could manage them better. So what do we know? Patients 6 months prior to death, many of them are alert and oriented, ambulatory, they're not in pain. That's not the way we see that. And because we provided no anticipatory guidance to our patients and families, they're reluctant to be moved prior to that last event onto a service that would keep them in home, supported in their place of residence. There's other things you can prognosticate about besides just death, and so it's or getting onto hospice. This was a study that looked at using ADLs to prognosticate for risk of hospitalization. And 6,000 patients, these have been validated studies now. If you have severe disability, is when you go from no previous ADL deficit to 3 ADL deficiencies, and gradual severe disability is 1 or 2 ADL deficits to 3. And so you can see that half those patients and 72% of those patients are going to be hospitalized in that year. So if you see, just using ADL, you can anticipate your patients who are likely to be hospitalized. So then you're adding all these things, general information, prognostic models, disease-specific and non-specific biomarkers, and you can get to a point where you're able to anticipate what's coming for your patients, especially as they get older, whether they've shown ADL change or not. And we all know how to prognosticate. Vital talks and others would tell us never say 6 months or less, but best case scenario, worst case scenario. I still hear people saying this, which is a tragedy, but it still happens. And the other thing is, you learn to say 100 people or 1,000 people, this is what the distribution would look like, and you can use your professional skills to nudge them to the left side or to the right side, but you don't ever say one time or date. And then their event prognostication to us is by far and away the most important tool, and we need to be reteaching us what's the next in the expected series of events. And in fact, we've all participated in event prognostication. Anybody know what it is? Whether you're a family physician or whether you're in healthcare or not, we've all participated in event prognostication. Anybody know what I'm talking about? If you didn't do it, you wouldn't be allowed to practice healthcare, and that's called anticipatory guidance in children. Yeah. You have to learn it. But guess what? The same thing happens on the other side of the bell curve. We just have to start teaching anticipatory guidance for disease processes. And when you do anticipatory guidance as children, I delivered hundreds of kids, although it's been a long time ago now. We told them at 1 day, 1 week, 1 month, 2 months, this is what you need to do to protect your kid. And we know in developmental milestones, kid's about to crawl, you make sure everything is picked up off the ground, all the curtains are up, the doors are locked. Matter of fact, I'm going to tell this group, see this mole? That mole my niece could see from way back there. When she was 4 months old, we were sitting on the ground playing with her, she was newborn, and she crawled over, grabbed my mole and stuck it in her mouth, or tried to stick it in her mouth. That's what kids do. And so you make sure everything is off the floor. And I used to work at Children's at Los Angeles. We pulled out cat food and dog food all the time because it just, people didn't get how important it was to keep things off the ground. But you do the same thing for, bathing your child. So if they're in you keep them 2 inches of tepid water. I don't care if something's burning on the stove, somebody's knocking on the door. We didn't have cell phones back then, or so if somebody was, the phone was ringing, you make the child safe first, and then you go and you can do whatever you need to do. And as family physicians or as pediatricians, when we retire, we did that because we didn't want the kids to drown. Now, what's the acceptable number of drownings when you retire as a physician? You know what's coming, you know how to prevent it. What's the acceptable number of drownings? Zero. So isn't that interesting then in healthcare, when you get to the other side of the bell curve of life, when you have a patient with heart failure, when you know what's coming and you know how to prevent it, what is the acceptable number of drownings for our patients in their own fluids with heart failure? That's a culture change. There are two ethical standards in healthcare, one for kids and one for adults. We make a lot of money off of fee-for-service for our drowning adults. I prefer the kids model. And so we took the kids model and applied it to adults and said, no more drownings. And I can tell you to this day, the number of heart failure patients on our transitions program since 2007, when we took our first patient, we prevent 90 to 94% compared to usual care. 90 to 94%. So let's just apply this to a patient so you can see what our program does. This is one of my patients. I had inherited him. He had a quadruple bypass and 2 stents. Using general information, he's 82. He had a pretty good BMI. It was 26, which is actually the nadir of mortality for people when they're older, 25 to 30. He was not depressed. He had a couple of ADL deficiencies. He comes in one day and says, well, I'm short of breath when I exert myself. So I can just tell you he had congestive heart failure. Do patients come in when they have stage 2 congestive heart failure? Or stage 1? No, they never tell you, because we don't ask, even though they have structural changes. Technically, it's still heart failure, but they don't come in to complain until it's stage 3. Using your biometric model of the New York Heart Association, how long do you last? I'm giving you a hint. How long do you last in stage 3? 5 years, yeah. And that hasn't changed for a long time. We may, with some of these new medicines, get another year or 2 out of it, but it's not a whole lot of change. And so every time he comes in, what are you doing? Because they're complaining a little bit more shortness of breath. We started with metoprolol and lisinopril. Then you add Lasix and DIG and hydralazine, spironolactone. So you can talk about more medications. The patient keeps thinking you're just going to keep doing that indefinitely. Why? Because they feel fine. So again, you're using your professional skills, and his ADL deficiencies haven't occurred. But you can monitor his BNP, disease-specific biomarker, until it starts to rise. He's on more medications. You know they're in using the prognostic modeling. He's got about 5 years. So the meds go up. Then eventually he comes in to see me and he says, well, Dr. Hoefer, I'm losing my urine. And what do you now know? Because I just showed it to you. That's his 3rd ADL deficiency. What's his likelihood of being hospitalized that year? 50%. You can look at other supportive data, non-specific biomarkers. Isn't that interesting? Because we put him on Lasix by that time, he developed intravascular volume depletion. We were keeping his blood pressure down, so it's 100 over 60, something like that. But at least his heart failure is being managed as well as possible. Some work by Thomas Haywood on a script showed that when their B1 gets to about 20 or 55 or 60, and they're pregnant about 2.5 or 3, they have about 6 months to go. Look at more non-specific biomarkers. You can see his hemoglobin dropping. You can actually look at red cell distribution with 2. It's just a brand new article came out of Sutter. And what do you see about his hemoglobin? It's dropping, and he's now anemic. What do we call that now? We used to call it anemia of chronic disease. Now we call it anemia of inflammation. And so if you go back, what do you do here when he has his 3rd ADL deficiency? You know what's coming, and you know how to prevent it. You put them on an in-home program because that's the time they need the most help. They need to have somebody available 24/7, 365 days of the year for the next few years, because something's going to happen and you want to be there for them. You don't want them to wait to call you at 7 in the morning. You don't want them to wonder what to do. They're so well supported with nurse and social workers and physician backup and their primary care physician all working as a team, that patient can take their HA kit at 2 in the morning when they start to cough and have a little bit more congestion, that they immediately take a Lasix and potassium, and they call the nurse, and that nurse will say, I'll either come out now or I'll come out in the morning, and we keep that patient out of the hospital. So we published this research in 2013 was the second article. 2010, I believe, was the first article. And the first article, I didn't realize I was a researcher, but I suddenly became a researcher. And then it was published out of Sharp when we were just developing our research department. And the California Healthcare Department saw what we were doing, and we partnered with DCU and Kathleen Kerr and Brian Castle, and we did palliative research at a much higher level. And this has now been cited in over, I think, 110 research articles around the world. And I want to just show you, sorry, Larry, but again, I guess you said it was okay to put financial results
Oh,
in
absolutely.
here. Yeah, so this is the PMPM cost savings by proactive end-stage management. These are the hospital cost savings. Usual care is in red. The cost for our patients is in blue. People said, well, you're saving money because you're spending more money in the outpatient arena. That's not true. In fact, it was an original research, statistically significant, to show that we could save money on dementia patients. And by the PMPMs for heart failure, COPD, and dementia, you have to multiply those PMPMs by 7.2 and the cancer patients by 5. And you can see the total healthcare costs. There's a 30,000 cost savings per heart or per COPD patient. 100 heart COPD patients, you save $3 million. Think you can do that? Yeah. So it's very powerful. However, this is my favorite slide. This is why I helped create this program. Because blue are the number of patients that were hospitalized. Red was usual care in San Diego. So I can tell you now that most of my patients will never see the inside of the hospital because we put them on this program. These patients in blue never saw the inside of the hospital. Patients in red, usual care, even if they were the kindest, most compassionate, somebody said it earlier in this today, it says compassion's not enough. You have to have the tools to make it possible that those patients can stay at home. And then I put this slide in here. These are deaths in the hospital. So who's going to prevent deaths in the hospital? The hospital or family physicians? Family physicians are going to prevent deaths in the hospital. You can't go into the silo where something occurs every single time and try to fix it in the silo. You have to fix it 1, 2, 3 silos upstream. We're that person. And then here's something else important. You can see that most of that cost savings is people are waiting for that last 1 or 2 hospitalizations before they do something that's just far too late to wait that long into the process. Also, I want to show you something. If you go too far out, you don't save any money. Doesn't mean you shouldn't do it, but there's no real cost savings to do this 3 years out. And that's one of the reasons we wait to admit people until they're at risk of starting to use the hospital. So this is just comparative data. Richard Brumley at Kaiser did this, but they only averaged the last 2 months. We averaged the last 6 months. So interestingly, we had the same cost savings, but it was over a 6-month period. And then what percentage of our patients go on to hospice? Almost 90% across the board. And they're on, except for cancer, they're on significantly longer than the national average. And that's a Likert scale. Family satisfaction with the care for their loved one. It's very difficult to get high scores when you're dealing with a dying loved one. If it was a 4, the lowest percentage there would be 94%. And that's the program. And that's what we did. 2005 was conceptualized. Took our first patient in 2007. We accept all diagnoses across the board. And I can tell you that, to me, I just can't imagine going back to letting my patients go to the hospital for decompensation care. There was a time, COVID kind of screwed everything up, but there was a time where I could say I can count on one hand how many of my heart failure patients had been sent to the hospital. And you might have looked on that slide and said, well, Dr. Hoefer, you said that you decreased heart failure exacerbations by 90 to 94%, but the admissions to the hospital for heart failure were 44%, and that's because of falls. Falls are the #1 reason for admission to the hospital for heart failure patients. They're a third as likely to be readmitted, and they're in the hospital for a shorter period of time. And I'll tell you one of the problems with this program. It is so embedded in our vernacular to talk about preventing readmissions that people can't conceptualize preventing primary admissions. And so we have to get away from that vernacular and start saying, why are they going there at all? So anyways, that's the story, and if you're continuing to do this, hopefully we'll be around for another 100 years. Any questions?